Good morning, everybody. Good afternoon, and thank you very much to the INMO for inviting me here this morning. And what a great theme, innovation in practice and nurses and midwives leading the way. My name is Brien. I'm a clinical midwife specialist in teenage pregnancy, and I'm there to improve maternity services for all the teenage population that attend our unit. And I've been asked to answer 4 questions, but just before I do, I just want to bring you into the world of teenage pregnancy in our hospital. Teenage pregnancy, a teenage or an underage girl within the ages of 13 to 19 becoming pregnant. And this can vary in different countries around the world. And it does remain a major public health concern worldwide. In the UK, it continues to have one of the highest rates of teenage pregnancy despite recent decreases in birth. And they are working very hard on their 10-year strategy to reduce teenage pregnancies. In Ireland last year, we had, in 2016, we had 1,098 teenage births in Ireland. And in 2017, the figures are nearly done, and it was 822 births for the first 9 months of the year. And 63 were those to underage teenage mothers under child protection. And they are the girls under 16, so between the ages of 13 to 16. In our Lady of Lourdes maternity unit, we had 2.3% were to teenage mothers. So pregnancy may be the first and only time a teenager interacts with the health services. So it's a vital opportunity for health education for these young population. So we have to learn from studies and large cohort studies that have been done all over the world. And the last one that I was involved in a publication in 2014 called The Management of Teenage Pregnancy with Professor Louise Nolan. And these are some of the statistics that we found. So large cohort studies have found teenage mothers are more likely to be late booking into the maternity hospitals, less likely to access maternity care, poor attenders at the antenatal clinics, poor attenders at our antenatal education classes, increased association with smoking, alcohol and drug abuse. Studies have shown an association between child and sexual abuse in childhood and mental health issues in teenage pregnancies. Studies have also shown an increase in STIs, sexually transmitted infections. There has been increased risk of postnatal depression in the first year of life compared to the older mothers. Studies have shown poor, inadequate diets among this cohort of teenagers and a higher risk of repeated unplanned pregnancy. Studies show up to 25% of all our teenage mothers deliver a second baby in their teenage years. Teenage pregnancy is associated with considerable socio-economic deprivation, and mothers are less likely to breastfeed, showing poor breastfeeding rates. Studies also show an increased risk to both the mother and to the baby. So in the chart here, you can see that between the mother and the child where the impacts show. The social impacts, social isolation, lack of qualifications, not completing their education, receiving welfare benefits and not living independently. The social impacts are more likely to become a teenage mother. The medical impacts, reduced birth weight, higher risk of death, growth restriction for the young baby, not breastfed, infection and sudden infant deaths. And the medical impacts, urinary tract infections, STDs, premature death, premature birth, preeclampsia, which is high blood pressure in pregnancy, anemia and depression. And while it all sounds very gloom, certainly in our clinic there are lots of young girls who have gone through and have educated and have a great support and great family background and have come on very well. But we have to learn from all the studies that have been done academically, and that's where we move forward. So in our Lady of Lourdes maternity unit, the improvements in quality care initiatives, we have learned from our literature looking at previous studies. Our Lady of Lourdes Hospital Maternity Unit was the first hospital in Ireland to designate a clinical midwife specialist in teenage pregnancy in 2010, and this was to improve maternity services for the young girls that attend our unit. So what kind of improvements have we done since we started in 2010? So at the end of every year, we try and bring out some kind of initiative, learning from our studies where we can improve. So the first one we looked at was the antenatal classes, where only 20% of young mothers were attending these classes. So we have increased that now to 97% of all teenagers which actually come to the antenatal classes. So young teenagers that are breastfeeding, we've increased that from 27% initiation rate in 2014 to 42% feeding in 2017. So pregnant teenagers that are smoking throughout pregnancy, we've done a lot of work in that, and 4.1% quit in pregnancy in 2014 and 40% quit smoking in pregnancy in 2017. And there's been a lot of work done regarding the NICE guidelines. So using carbon monoxide testing, we've learned as well from the NICE guidelines, and we're bringing that in for all women as well. But in the teenagers, in the teenage antenatal classes, they are using carbon monoxide, and a lot of work goes into that. And it's another presentation to learn how we got to those statistics, but we won't go to that today. In 2017, we made, through the Policy and Guideline Committee, teenage pregnancy guidelines were written up for all staff. And this, of course, improves quality of care throughout the whole unit. A contribution to the reduction in the repeated unplanned pregnancy within 3 years. In 2011, 25% of our teenagers come back and were pregnant the following year. In 2012, 18%, 2013, 11%, and just looking at last year's statistics, 9%. So we're definitely contributing to helping all those young teenage mothers. So in 2018 and 19, we've got loads of new initiatives in progress, but that's top secret until the next one. So let's see how the questions should be answered that they've asked me to talk about this morning. And that was, how has the teenage pregnancy service in our hospital enhanced services for clients in the area of teenage pregnancy? So having a designated clinical midwife specialist, being an expert practitioner in all matters of teenage pregnancy and who has complete continuity of care, builds up a rapport with the pregnant teenager, young father and families, and this has shown improvements in the quality, thus enhancing the service. Educating staff and students in the specialist area brings education and evidence-based practice to the multidisciplinary teams, enhancing the services. So the CMS, myself, having professional development myself and to keep myself on top of everything that is going on, having my crisis pregnancy course done, my contraception course done, having the antenatal education course done and bringing about changes, having my smoking cessation done and linking in with my drug liaison midwives, mental health midwives, breastfeeding courses, keep myself on top of my own professional development, and the STI specialist, and we're very lucky to have somebody there the first Friday and last Friday of every month in our hospital, and attend appropriate study days, and having expertise knowledge will bring expertise to the service and thus enhancing all the services. So I've shown you about the antenatal classes, the breastfeeding, pregnancy, the quit smoking, the teenage pregnancy guidelines, and contributing to a reduction of these repeated unplanned pregnancies. And lastly, by improving health literacy for our clients and our young girls, helping pregnant teenagers and those under child protection to understand health information correctly and that they can make an informed decision through our Teen Mums to Be Facebook page, through our Twitter and our texting services, and a one-to-one individual midwifery care throughout her pregnancy with the CMS. So speaking in a language that health users understand, it is what health literacy is all about, irrespective of their background. So how busy is the service? In the next slide, we'll show you the clinical area of where I work in the hospital. And other than that, there's the administration work. The audits, the presentations, the guidelines, the policies, your yearly annual reports that everybody knows about, your social worker meetings, your teen parenting support meetings, your emails, your connecting with the multidisciplinary team, your family meetings with families, your CNS meetings, meeting with your bereavement and your health midwives, your smoking cessation meetings and keeping yourself up to date, evaluation forms, looking at how the girls have got on, your college students, your phone calls. I have a phone that I have since 2010, so I rang Vodafone to see how many texts were there in the last 10 years, but they couldn't give me that, but they gave me some idea from last year. But I said if there was a murder investigation, I'd say you'd know how many texts went in and out. so anyway. So anyway, last year they told me that in the first few months there were 729 texts from the young teenagers that came into the mobile. And the Facebook page last week as well, when I put up a post on the Facebook page, within 7 minutes there's 300 connects onto the Facebook page. So hospital and national presentations, maintaining a constant database of teenagers with the maternity information system. And that's a great help to me as well, and that's where we get a lot of our statistics. So if you just look a little tiny bit there about, you can see there Can everybody see that dot as I go through it, yeah? So you just see there on the right-hand side, you can see where the girl, let's start here with the very first sexual relationship there. The pregnancy test is positive, and then she tells somebody about this pregnancy. Then she goes to see her visit to her GP. Then the letter is sent to the hospital by the GP, and the appointment is sent to the teenage mother. So then she comes on a Friday morning to the teenage pregnancy booking clinic, and that's where she meets me. And I'm lucky to have that time to be able to spend with her and her family to link her into the services. And that's where she has her first scan, and she screens for the midwifery-led unit that we've here in Drogheda, whether she can have her baby there or not. So we link her into the smoking cessation immediately there. I talk to her about the breastfeeding, and I'm lucky that I have the time to spend with this young girl. The social worker is there, the girls between the ages of 13, 14, 15 and 16. So it doesn't make referral to the social worker too daunting for the teenager. So now we have the actual social worker there when the girl comes in. So having the two of us there as her support makes it much easier for the young girl. Then with the combined care, and she comes back again to us. They have my ongoing Teen Mums to Be Facebook page, and they have the texting service throughout their whole pregnancy. And here you can see that we have the antenatal class, the breastfeeding teenager coming into the class. That's helped to increase the breastfeeding. We've got a postnatal depression talk, and a teenager comes in to try and get her to tell the other teenagers to access services quickly. And when she talks at the class, it does help a lot. So we have the normal antenatal class then done, and a tour. So then she has her baby, and I visit her in the mornings when I come in. I do a round and see all the girls that have been admitted and the girls that are in the postnatal. And here we have the when she's discharged home and how they get on. They come back to do a reunion class. Mothers and babies all come back, and that's how we can improve our maternity services. And back to school again then, and the cycle hopefully doesn't go on and continue. So is it a service that prevents or reduces hospital admissions and attendance to the ED and attendance to the GP services? So this teenage pregnancy service has to reduce hospital admissions or attendance to the ED and GPs, as the CMS in teenage pregnancy has a mobile and texting service that all teenagers booked into our hospital can access for pregnancy advice. For example, last week one girl said, well, I go to my GP, this is what's wrong, so I just gave her the advice, so there was no link into the GP. Another one was, well, I go to the ED, I'm worried about this, and the answer was, no need, come into the walk-in clinic, it's on today, hence the hospital admissions are reduced as the problem is then sorted in the walk-in clinic that morning. The Facebook support and texting service and the one-to-one support is the interlink between the services. The CMS solves the problem unless otherwise indicated. So in all, how has the role contributed to the job satisfaction of the nursing and midwifery team? So in all aspects of healthcare, for all of us here today, when we see improvements in the quality of care, this is job satisfaction for us as a team, for both the clients, the multidisciplinary team, and the CMS in teenage pregnancy. The girls filling out their evaluation forms of the service, the positive comments, the reunion classes after the birth of their baby, to hear back and evaluate the service and to improve the quality of care. So lastly, there's a beautiful old Irish saying that my late father used to quote, and that went, Ska Céla Varas Nadina. And that means that we all live in each other's shadows, or we live under the shelter of each other. In other words, we're all connected to each other, live, thrive and struggle, not alone but together. The people here today illustrates that none of us are really sole practitioners, that the health system is not a collection of individuals, but a connected system of human endeavour. And I may be the umbrella as a clinical midwife specialist in teenage pregnancy, but it's our managers, Mary Gorman, who's here today, who's part of the INMO, and also Grania Millen, who's our Director of Midwifery. Without their support for me to help me to do my job, it can't be done. So it's all our team that make it all happen.
Well done.
Thank you.